Yes.
But our next speaker is Dr. Abigail Languish. She is the obstetric lead for triage at the University Hospital in Dorset. And she is going to be talking about the role of the triage midwifery ACP with the obstetric perspective on it. Thank you, Abigail.
Hi, thank you. Thank you for having me today. And certainly, we will try to answer and maybe elaborate a little bit on more of those questions that were heard in the interval. And so I will just share my presentation just to help guide the discussion so I don't go off on too much of a tangent. So yes, I've been asked to talk through the role of the ACP midwife in our triage from an obstetric perspective. And as we've heard from Sam's been working within our maternity triage and antenatal clinics since November 22, but I'm hoping to cover sort of the why, the how, and what the outcomes have been from having a midwifery ACP working with us at University Hospital Dorset. So before Sam started within her role as an ACP with us, our maternity triage needed a lot of development and quality improvement, as we were finding there was very long waits for patients. And because of those waits for patients to see medical staff, there was an increased number of patients self-discharging before they'd had those medical reviews. We found that patients had negative feedback for us because there's a lack of continuity of care. And that was a lot to do with junior doctors' rotas and how junior doctors change their shift pattern frequently throughout the week. And it identified a need to be able to improve patient safety and experience because of those aspects that we found. And we really wanted to try something new. I think we can all agree that our maternity triages really benefit from having experienced clinicians working within the departments. And we find that lots of senior midwives that have been working within maternity departments for a long period of time want to be able to progress, but not necessarily progress into the midwifery matron roles, such as midwifery matrons. And so it has seemed and has definitely worked out to be a perfect way to be able to progress in terms of clinical work for midwives, and certainly has developed that role really well. To try something new, obviously Sam has talked through her training, and Sam was supported by myself, another obstetric consultant, and consultant midwives throughout her training. And that allowed a period of time, well, obviously 3 years for her master's course, for us to become familiar with what the role could be, the breadth of skills and knowledge that ACPs are learned to manage and to be able to deal with within our clinical scenarios. And it developed this trusting relationship between the consultant obstetricians within our department and Sam to be able to provide some confidence for this role going forward. And so then it came to a point in November 22 where we wanted to employ Sam to be able to be an ACP within our department. And because we had supported her training, there was that trusting relationship and confidence about the role. So as I've mentioned, we supported Sam throughout her training by consultant midwives and consultant obstetricians. And it gave us experience of the role. We'd be able to understand the role, but also to understand the breadth of training. And as Sam has talked about, she has spent a lot of time within A&E, within gynecology, within medical specialities, and so has been able to sample a lot of the medical problems and deal with medical problems of pregnant women that come into the maternity triage. And that's not to say that Sam's role is developing to be a medic, but is being able to expand her midwifery knowledge and bring that medical knowledge into her midwifery experience and insights. As I was talking about, through the supporting of her training, where there was that trusting relationship and confidence within the role, there was very much then a unanimous decision within the consultant obstetricians and gynecologists at UHD that employing an ACP would be a good way forward. And I think it's really important to be able to have that unanimous decision. So ACPs are supported within the antenatal clinics and within whichever well, for triage for UHD, but whichever sector they choose to base themselves in. So they are supported 24 hours a day, whichever day they are working. So when we began to think about employing Sam as our ACP, we really wanted to have a robust, detailed job description. And so Sam and I spent a long time writing this to be able to give her support, that this was what should be allowed, sounds the wrong word, but what she'd be expected to be able to do, but also to give her, if she was to be challenged by any other professional within our department or hospital, that this is what her role would encompass. And so I feel it's really important to have a detailed job description, always to refer back to. Within our department at the time in 2022, like Sam mentioned in the questions, there wasn't the midwifery budget to be able to employ an ACP at an AA banding. And we didn't want to lose a really experienced midwife and also a dedicated midwife that has put themselves through the 3-year master's programme. And so for us at UHD at the time, it felt the right way to support this role through the medical workforce budget. But that will differ from hospital to hospital, maternity department to maternity department. And there is no, I don't think, particularly right and wrong answer about how ACPs are funded. It's about what works for that department and where the appetite sits. Sam has her own rota, like she was talking about, where Monday to Friday she works within our maternity triage and our antenatal clinic setting. And then because Sam is employed by our medical workforce budget, she takes part in a 1 in 4 weekend rota, working long days at the weekend, usually within maternity triage, or can be part of the general SHO obstetric rota. This is, again, not to say that Sam is replacing a member of the medical team, because that is certainly not the case. We very much understand the roles and responsibilities of a midwifery ACP, and we all understand where the lines in the sand are, so to speak. But that's certainly how we have found it's worked well for us within our department. Supervision. Sam and I have taken 6 weekly supervision meetings over the course of her employment to make sure that her understanding and competency and how she feels whilst working the maternity triage is well supported. And certainly that has been really positive. And I hope that Sam has felt supported by the obstetric workforce and having that really frequent supervision. But also Sam is supervised by our consultant midwifery team as well. So within the job description that we formulated, these are some of the ACP responsibilities and duties within UHD. So it's clinical assessment of patients within triage and the antenatal team, working alongside the SHOs, registrars and consultants. And certainly Sam is very much a champion for our maternity triage. And it has been myself and Sam that have worked together for about 4 years now to be able to develop our maternity triage to where we are today. She has independent specialist interests with hypertension management and growth restriction management. And we're just about to start some research undertaking postnatal hypertension management within our service and within the Wessex region as well. In terms of leadership, Sam's our lead for our Saving Babies' Lives programme, with a particular focus on the fetal growth surveillance, as that's one of her specialist interests. And Sam's leadership and data collection for this area then contributes into our Saving Babies' Lives work stream for our department. She most definitely contributes to midwifery formal and bedside teaching, really supporting the midwives within triage to be able to take good short snap triage histories, to be able to support them with their clinical assessments, CTG interpretation, speculum examinations. And I think that formal and informal training also then goes along to support our junior doctors as well, especially our GP trainees who, as you have all experienced, will come into our maternity departments having not a great deal of knowledge about pregnancy, and certainly they need a lot of support and upskilling in their initial weeks and months whilst they rotate into our departments. This kind of describes a little bit more about the support that ACPs, I think, can give our midwifery and junior doctor workforce, because we are a team that works together to look after patients and families. And I don't think although there is a divide about midwifery training and medical training and the workforce and the rotas, and there are those divides, we really do need to be able to come together and work as a team and use each other's strengths and weaknesses to be able to provide excellent care and to keep patients safe. And I think ACPs are able to bridge that gap fantastically and bring teams together, being able to support all members of the team whilst working in a particular area. And I think being able to work this way has contributed massively to patient safety and improved patient experience. So definite positives of the ACP role is that we have a senior midwife within maternity triage that is dedicated and is able to support the team and to be able to see patients in a timely manner. I think Sam has more time for patients compared to our junior doctor colleagues. She is able to spend more time taking assessments, examination, and I think the explanation of management of their problem, whichever the problem that may be, is definitely a lot more holistic. And the advice and recommendations are explained in a much more pregnancy-friendly midwifery approach, where sometimes being a doctor, these can often be explained in a very clinical way. And so patients find the explanations that of their care that perhaps an ACP or SAM has given is a lot easier to understand and can become a lot more logical for them. She's most definitely a patient advocate, and certainly if patients are wanting to not follow advice or perhaps have their pregnancy or care outside of guidance, Sam is able to try and be that advocate for their patient and explain their wishes to the consultant midwives and to the consultant obstetricians. So we're able to formulate safe plans for patients as well. And again, this gives improved safety and a better patient experience. So then linking all of this back to our key performance indicators within maternity triage, we have definitely moved streets ahead compared to when we first implemented maternity triage and the BSOT system within UHD. And we now have a 97% compliance with the 15-minute midwifery triage time. And certainly having dedicated ACP within triage, working alongside our SHOs and registrars, we have an 80% compliance at the senior review times. Obviously, Sam mentioned before that BSOT's team have taken away the doctor review times with their algorithm, but certainly within our trust, we have kept these. We have made them a little bit more realistic and flexible, but certainly keeping them safe, because we don't want patients to be waiting long periods of time, because that ultimately leads to patient self-discharging, which can then be unsafe. Our sort of triage is now functioning very well, as you can tell by our compliance times. And I think the midwifery team within Triage is much happier because they have an experienced clinician to discuss cases with the vast majority of the time. And certainly it's improved patient safety. And we have had no serious untoward events within maternity triage for about 2 years now. The ACP role, I believe, has really fostered good working relationships and has helped to bring the medical and midwifery workforces together, which I think is essential. And we most definitely have improved patient feedback and satisfaction. Now, I realise my talk is a little bit shorter than the length of time allocated to me, but I think this is a really interesting area to have questions and discussion about. And certainly, I think it'd be a really good idea to have that now and perhaps expand on some of the questions and answers that was given in the previous break.
Perfect. Thank you, Abby. I'm sure the questions will start coming through in a moment. They haven't come through yet, but it was something that I was thinking about as you were talking is how do you, because obviously you and Sam work very closely together and have a good working relationship, but how do your colleagues feel? Is there kind of universal support of the ACP role? Were there any barriers when it first started? What's your experience from the wider medical team?
I think the experience of our wider medical team has been really positive. And like I said, whilst we were implementing Sam's role, there was a unanimous decision that this was the right way forward for within our department. And certainly all of my consultant colleagues, I think, have a good relationship with Sam, trust her clinical assessments and clinical judgment. Because certainly Sam is working with them on a daily basis to talk about complex patients from antenatal clinic and from maternity triage. When it came to employing Sam, we didn't really have many barriers because we did have that unanimous support. The team was very keen for her to be in post. I think what could possibly lead to barriers in ACPs being employed is their scope of practice. And because we have a very robust job description for Sam, there's a very clear understanding what her scope of practice is. I think those lines can become blurred when particularly there are ACPs that might want to undertake their specialist interest within labour ward care. And I think that's when there can be more blurring of the line and it could become a little bit more challenging. That would be my personal opinion.
Thank you. Someone is asking how Sam's role differs from the role of the physician's associate that works in triage as well.
So we have one physician's associate that works, she works within the whole obstetrics and gynecology department. So her role differs greatly. She's a physician associate that takes part rotating along through gynecology, through the gynecology clinics, but also works within labour ward, postnatal care, and within triage. So she's also a physician associate that hasn't completed her prescribing competency. So probably just from that description, you can see that her role differs a great deal. And certainly our physician's associate is not as experienced a clinician as Sam or another ACP would be. And so there is a definite difference there.
Thank you. Somebody's asking, it's great that there was excellent buy-in from the medical team. Was there any resistance from senior leadership and senior leadership in midwifery? And what was the feeling around the funding not coming out of the midwifery budget and coming out of the medical budget instead?
Sam not both smile. This has definitely been a big challenge, and I think will continue to be a challenge within our trust. I can't speak for our head of midwifery and our director of midwifery, but the midwifery matrons and heads have made it clear that there isn't the funding for this role. But of late, there has been lots of discussion within our LMNS about how this role can be funded in the future. And I think that's still a conversation that's ongoing. I find that our midwifery matrons are supportive of Sam's role because we are safe, we are innovating a new way forward, and we are most definitely wanting to be able to carry on employing experienced midwives, because this is about recruitment and retention as well. We want to keep our experienced midwives working within the NHS settings rather than going off into the wider MDT workplace. And so they are supportive of the role, but from afar.
Yeah.
That might all sound a bit woolly.
No, it's very diplomatic. And then people are asking if it would be possible for Sam's job description to be shared. So yeah.
Yeah, most definitely.
Yeah. Thank you. Another question. It's a long question.
That's okay.
Okay. So, and it says, women are presenting with many more medical conditions and higher risk pregnancies, and the ACP focuses on obstetric and pregnancy related health conditions. How do you ensure that there isn't misdiagnosis of medical conditions that the ACP may not have come across before, that a junior doctor may have seen through medical school and on rotation around other areas of medicine in their training?
So we purposely made sure that our ACP is rotated to work within daytime hours. Nighttime working becomes a lot more independent for that clinician. During the daytime, there's always colleagues to discuss cases with. And I think with Sam, we have found that she has excellent insight into her strengths and weaknesses and where the line is in terms of how far she is able to look after somebody. She has a very good sense of when to include the medical workforce in that patient's care. And certainly Sam has always discussed patients, particularly when it comes to before discharging, with registrar and consultant colleagues. As Sam has gained confidence in the 18 months that she's been employed in this role, she has found that she's been able to discharge patients much more easily and knows what follow-up to book for patients as well. And that has certainly been a learning curve. The reason why, obviously, Sam is employed by our medical workforce budget. It's very difficult to retain and employ junior medical staffing. But we have not wanted Sam to work on our night rota because there's a lot more exposure to being by yourself, which is what we don't want. We understand that ACPs do not have the same medical training as doctors. And if Sam was to, or an ACP was to work independently overnight, that could very easily lead to that ACP being very vulnerable and working outside of their scope of practice. And so we have felt by working in a daytime way, whether that's during the week or at the week or the weekend, there will always be a team around them to be able to ensure patient safety and that the right things are being requested and done, etc., etc.
Perfect, thank you. And then, so there's a comment here rather than a question, but it says, it's great that the budget was found from the medical workforce because you've been able to demonstrate the benefits. So in a way, it doesn't matter where the money came from at the beginning. Hopefully it will just be a launch pad.
Yeah, and that's exactly what we have found. It doesn't really matter where the money comes from. It has just got to be an opportunity to be able to expand this role. And I think it's really important that we are able to retain experienced midwives working within our departments, and this is a way forward.
Yeah, definitely. And then the next question is, Is there a separate lead for is there a separate midwifery lead for triage in addition to the ACP, or is Sam the lead and ACP in triage?
No, we have a separate lead. So we have a band 7 midwife who's our lead for triage and certainly is the line manager, so to speak, for our band 5s and 6s working within that area. And Sam's leadership within triage is more from a midwifery clinical leadership, research, audit, quality improvement leadership, rather than from workforce.
Perfect, thank you. And then somebody's asking if you know what the RCOG position on ACP midwifery roles is.
I don't think the RCOG has a position upon this at the moment, certainly nothing that I have read from them at all. But obviously Sam has spoken about in her previous presentation about how this is wanting to be supported. So I'm not aware of the RCOG having a position upon this at the moment.
Okay, thank you. That's all the questions that have come through for the time being, I think.
No problem.
Oh no, they're coming through again.
That's okay.
Okay, so somebody has said, according to Pippa Clark, the RCOG did make a position statement very recently. Perhaps Romy might know more about it.
Oh, thank you. I've obviously missed that, sorry.
Yeah, no, it's fine. Yeah, so I can't think of anything that I wanted to add. I think I don't know if you've thought of anything since you finished your presentation that you wanted to include before we finish.
No, I'm happy. But obviously, if there's any further questions, I can always be contacted via email.
Perfect. Oh, somebody else again is asking what banding the ACP role is paid at. So the banding for a qualified ACP, according to Agenda for Change, is a band 8A. Right. So
thank you for having me.
Thank you very much. Thank you.